Welcome back to ANC Connect, our new podcast. My name is Fasiha Hassan. Today I'm joined with Dr. Bandile Masuku as well as Esethu and we're going to be dispelling some of the myths, some of the fear-mongering of the national health insurance, but we're also going to talk about some of the things you're worried about, some of the things you're experiencing, and why the NHI is as important as it is. Let me introduce my guests officially. Let's start with you, Esethu.
Well, my name is Esethu and I work in government as a director for content and research. And I think I should add this, I'm not flaunting, because South Africans always ask, who are you to speak? I'm a master's student here at Wits, master's in governance. So NHI is one of the things that we do come across. So I will give a shout out to my professor, Professor Van Niekerk. He's a health expert in the field of NHI, and he does a lot of work that explains what NHI means, especially in the academic space. So thank you.
Yeah, see all your extras.
Yes.
Here it is. There's real people here who are actually qualified to talk on the matter. And Dr. Masuku, tell us about you just before we delve into the discussion.
Yeah, I'm Bandile Masuku. I'm a health practitioner, a qualified specialist in obstetrics and gynecology. I'm also a member of the ANC Provincial Executive Committee, passionate about education and health. And since we are going to be talking about NHI, we are one of the first group of people as a coordinator of the subcommittee of the National Executive Committee who initiated the first step to translate the resolution on the actual implementation and the adoption of NHI from the conference in Polokwane.
No, that's incredible. And I think many people don't realize. They think that NHI sort of just popcorned and bubbled up. And the reality is the idea of universal healthcare has been an ANC value from the very beginning. If I'm right, Dr. Abid Xuma is, for those who don't know at home, one of the early leaders of the ANC, before anyone really was actually involved. We're talking in the early 1900s. And there was this idea around African claims and universal healthcare. And really why we are here today is that effectively we have a medical apartheid. There are two different healthcare systems. And the unfortunate truth is that right now, 80% of the population is getting what we call 50% of resources. And then the 20% are getting the other 50%. So it's wholly, the scale doesn't really quite add up. Dr. Masuku, I'll say Comrade Bandile, we're having a conversation.
We prefer that one.
Let's do that.
Yeah.
Let's do that. Maybe you can take us through some of this idea of the cost drivers, of what drives healthcare and the price of it.
I think most of our experience that we have seen, in government and also elsewhere, is that there are three main cost drivers of healthcare, which in a way they are preventable and manageable if detected early. The three cost drivers being trauma-related injuries and causes, which are from your motor vehicle accidents or people assaulting each other. And all that, it's actually driven and underlined slightly by alcohol. And the second cost driver is the one of lifestyle disease, which we know it's hypertension, it's diabetes, and all these are manageable when we adjust and modify what we eat and how we live in terms of smoking and drinking and actually exercising. The third one is the cancers, which are the big cancers, a big problem. And we've seen quite a spike of incidences of cancers recently, but most of them, when they're detected early, they are actually manageable. And some of them are actually preventable, like your cancer of the cervix, which is the cancer of the mouth of the womb, is actually preventable with vaccines now. And these are the cost drivers. And in essence, in our country, we have a hospice-centric orientated healthcare. We wait for people to get sick. And I think one of the things that we should be driving when we discuss the national health insurance is just transforming the healthcare system and focusing more on prevention and also focusing on primary health care. But mainly it should be about prevention, because there won't be any amount of money in the world that will cater and be enough or sufficient for a hospice-centric system. You can look at all the other examples in the world, in the United States and elsewhere. You will see that, it becomes expensive. You only wait for people to get sick and then treat them. So prevention is better than cure, and it's cheaper.
I want us to talk about some of these myths, right? And one of those myths, we see it all the time on social media. You see it from some learned people, but you also see it from people who aren't also quite sure.
Yeah.
They say the public healthcare system's collapsed.
Yes.
I don't know. What are your thoughts?
And they reference people like me who are from rural areas or stay in rural areas. And if I would give my own personal experience, like I come from a place called Engqeleni in Eastern Cape. My rural community is called Enzwagazi. So I'm old enough to remember that at some point we did not have a clinic. So we would have nurses coming from the Department of Health once a week, and they would go to a traditional leadership's home to service people. So you did not have a clinic daily, so you'd go there once. But in the early 2000s, we got a clinic, so the clinic would be open for the rest of the week. It would be able to service people. You might not go there and get immediate help, like in and out in an hour, but you'd go and see a nurse and see a doctor and get medication. So the discussion online currently is that the healthcare system in South Africa has collapsed, and that is the word that they are using. So we always wonder if that's a fair statement to make, because we have these experiences of challenges in the healthcare, but we do go there and get help. And we don't know if going there and getting help really fits into a description of a collapsed healthcare.
I don't think it's collapsed, and I think we should give it a historic, in perspective, because 30 years ago we had fragmented healthcare system, in a way that you would find all the Bantu stands had their own, health departments. So pulling them together, and also the provincial administrations at the time, I think in Gauteng we had a Transvaal Provincial Administration, pulling that together and creating a bigger system that will actually cater for the majority of the people was a big, actual matter, and one of the priorities that the ANC had to start to do. And after we've opened up, hospitals like in Gauteng, like your Helen Joseph and your Charlotte Maxeke, two other interracial groups, then we started to see that it's not collapsing, but there is a pressure, and of course, the quality might be a bit of an issue there, because you can wait a bit longer for other things. The waiting times are a big question. But the issue is that the healthcare system does serve, and it does give the best, service in healthcare. Private. I know that I don't really like talking about private, but the issue about private is that most of the things that are said to be good or quality in private, actually, it's just the hotel service that they give. In terms of food and catering and the bed and having a TV, in front of you. That's the luxury. But I think maybe we want to get to that point where people don't wait longer, people do get quality care, and people do get enough food and nutritious food, when they are there.
In fact, I was reading around the same public healthcare system, which actually treats the majority of TB patients are treated in the public healthcare system. The majority of HIV patients, and in fact, the peak of our fight against HIV/AIDS, the most successful points of it are actually, if I'm right, Doc, in the public healthcare system.
No, actually, that's where we gather even the experience for research, and in private, in essence, they do what we call, niceties and luxuries. They don't really delve into the beast of, of the problem. And we see our healthcare system in the country. Yes, it might be a big talking point, if South African healthcare system has collapsed, why is it that it's the most in demand in the Southern Africa, for example. So in Gauteng, for example, we do see 3 medical schools and 3 central hospitals, which are doing absolutely great stuff in terms of innovation, in terms of operations that they've done. And we see this more, in the public sector. And it's because of collaboration, it's because of shared experience and knowledge amongst professors and all the people that are working there. So in a sense, there's no collapsed system. The system is there, it's sustained. Yes, it is under strain, but it is actually pulling on.
Let's talk about the strain, because that's another thing that a lot of people may not always understand. And I think there's acknowledgement from all of us that the public healthcare system is under strain. And perhaps because people are stretched thin and perhaps there's under-resourcing, isn't that more of an argument for NHI?
Well, just to add on the issue of a strained public healthcare, a lot of people, again, online are discussing the fact that ANC hasn't done anything to build infrastructure after 1994. And as people associated with the ANC have been at pains to say, over 50 hospitals, for example, have been built since 1994. Over 1,500 clinics have been built. And the fact that the public healthcare has 200 more hospitals than the private healthcare. So it caters for more people. It's overstressed, but there has been work that has been done. So in the context of a collapsed healthcare, it doesn't really make sense to justify when 50 million plus people are still going to these services and they are still getting help, especially when you mention the issue of TB and HIV. And all these things are things that people in rural areas battle with. And they are serviced every day. So another thing, just to come to your question so that the doctor can respond for us, is that a lot of people think that because there's NHI, all of a sudden, in your private clinic or your private hospital, you will have to now wait in a queue with everyone. So there is a panic of a pandemic panic that all of a sudden people will wake up and go to hospital. On my personal experience, where I come from again, I could not just rock up at hospital. I would have to start at a clinic or you start with a GP and you get referral to a hospital. So those practicalities, those myths and fears, are we all going to start abandoning our clinic and hospitals and just running straight to private care? How would the system work?
Yeah, I think it's something that I saw the TikTok video, of the NHI in Mill Park or somewhere.
Yes, and then all the different characters and role playing.
Hanging out on the window. I want gold teeth. I want braces. I want a liposuction and so on.
Yes, it's the same one.
So the most important thing, that's why I brought in the element of a hospice-centric actual system. Because if we look at it, that's how even private healthcare works, is that people will go to a doctor at any given time, and they will also go to any private hospital at any given time. But the medical aids themselves, they actually regulate that movement. They make it very clear that you go to a GP, you get a referral. So the GP must assess and ascertain that definitely you require a specialist treatment, and they will then refer you to a specialist. And also in that light is that there are also doctors who are also in what we call a network. So it's not like you go outside even the network.
That key care kind of thing.
So the number of things that the medical aids are doing, which when you look at it from the other side, because there's National Health Insurance Fund that might seem to give some form of restrictions and some of a system to actually to afford people to be able to access a healthcare system in an orderly way and also following on all the steps, then it becomes a problem. Yes, indeed, first you have to see a GP, you have to go to a clinic, and then they will then decide on whether you are you require a higher level of treatment. And
you
it's
don't
not
just rock up
anyway.
Yeah.
You know,
in a
like
demand gold
hospital,
teeth,
yes.
liposuction, and the
like
rest.
when you go to a specialist, when I see a patient now that comes without a referral, medical aids sometimes don't pay your claim because they feel that the patient didn't go to the first primary assessment to get to the point where they see a specialist. So these are things, that's how the healthcare system works, but it's because it's government will be running and
There's
will
now
be
a
putting the
different vibe
rules.
on
So
it.
now there's a different vibe altogether. But maybe also, as we spoke about that video, the issue of some of the procedures that are mentioned in the video are not necessarily the ones that would be covered by the National Health Insurance. What will cover is mostly the ones that require life-saving and that are actually essential. Liposuction, BBL, and so on are not going
They're
to be
nice
part
to have. Some of us require those things, BBLs and the other, but right now we're just stuck to gymming and squatting 1,000 times. Eh?
Do it the natural
Yeah,
way.
the Dutch way. I want us to talk about medical aids because this is something where so many people in our country are afraid. They're afraid that my medical aid, firstly, my premium will go up. That's a view. That if NHI is implemented, the premium will go up, the quality of healthcare will fall. But also, let's be honest, this is my view. I think medical aids have been taking advantage of our people for a very long time.
They've been making a lot of profit, and I think one thing about, medical aids is that I normally say to even, the patients that I see that they're almost a scam because they don't really want to pay for anything. Even when the patient requires, actually treatment, we have to write loads and loads of motivations. Your claim would be reviewed by someone who said no.
An actuary,
why did you choose this, not this one, and so on. So the actual functioning of medical aids, the baseline of it is that they're all about profit. They are not. When they say they're saving money or they're trying to save money, it's not for them to be able to give another person. It's for them to be able to make profit. They make profit. Their executives and board and so on and shareholders make profit even when you are told as a patient that you have run out of funds.
Yeah, and this happens all the time, right? Before the year is out, so many people will say to you, well, I've run out of funds, I have to make co-payments. And when you actually sit, and I've done this exercise, right? And you calculate how much you pay in premiums vis-a-vis what you actually get back. You can even work it out how much the medicine costs, all of that. You actually would have been cheaper for you to pay for it yourself.
Yes. No, like last year I was hospitalized. I had an infection. So what happened was that it amazed me that it was my first time being hospitalized at a private hospital. I've been hospitalized before. There's a hospital in Observatory in Cape Town, that big hospital there.
Krugerskier.
Yes, that one. I've been hospitalized there. I thought the care was brilliant. So I was hospitalized last year. But basically that when I was sitting, when I was at the reception, so they had to make a call to my medical aid and ask if I'm covered for what I needed to be hospitalized for. And
this while you are sick?
While I'm sick, I need to be in a hospital bed, but they needed to check if we can allow this person in. So if I did not have the money, I would have had to go back home, or basically have to go back to a public hospital, which was not going to be a problem. But the fact that you can be rejected at a reception while you are sick because your medical aid can't cover for you, or you have to pay it for yourself, is a concern. So NHI, how is it going to address some of those issues, especially when you are sick? Now you don't have to be tempted.
The simple way of understanding it is that you'll have to go to a clinic. Let's say you have a headache. You go to a clinic, they assess, and in most instances, Prof. Mawala, I'm sure he won't mind that we mention him. When he was studying in the UK, he said he had a headache, but there was NHS there. you know, and he called in to make an appointment because that's how it works, you know, with the GP or the clinic.
Yeah, you can't just soma rock up.
And then when he called, they told him, take aspirin or take,
Yeah.
you know, something for your headache. And then if it persists, then we'll make an appointment for you, you know. So here is that you have to make an appointment, get assessed. And if your headache, because headaches can have many causes, then if it requires further investigation, then you're then moved to, you know, actually in a hospital. So NHI, in its basic principle, is that we don't want anyone to pay out of pocket at the point of care.
Yes.
You know, that's the most important
That's
thing.
key.
That no one must pay at a point of care, particularly when they require, you know, the service that they or the treatment that they, you know, they do.
Or run out of funds while I'm still in hospital, and then I have to ask my friends to raise money for me to cover the bill.
That's where we use the term, you know, the term that is used in the language of universal health coverage is that we don't want anyone to suffer a catastrophic setback financially seeking healthcare. You know, and when it's catastrophic means that you can lose a house.
Yeah.
You know, you have to sell a house. Your kids must not go to school, you know, because you require, you know, actually healthcare. Those are events and activities that shouldn't be disrupted because somebody is sick. But of course, there is a system to it, and that should be actually, you know, respected. So you won't run out of funds, particularly when the care is required.
Yes.
You know, because there won't be anywhere where you would go to after that. You know, so imagine if that happens when you're at bar and then they say you've run out of funds.
Go home.
Then it means go
That's
home.
what I wanted to say. I mean, there are incidences, and you also see it not only on social media. You see it, right? You're coming today. We also had to do research, but also as a general person in society, before, well, I would like to think, before we formulate strong opinions about stuff, we should do a bit of research. And one of the things that came out was, I mean, there are people in private healthcare who were in ICU beds, ran out of funds, and were forced, quite literally, to be removed from ICU. And I mean, these are, like you said, critically sick, ill patients.
Yeah, and it's something that happens almost all the time. And when the medical aid run out, you know, it's the public service or the public sector that has to take up the, you know, even babies that are born prematurely, you know, in many instances, you have to pay upfront in some of the hospitals.
Yeah, the babies don't have the medical aid,
right? You're about to give birth to a preterm baby, and they might require, or they will require, ICU management, which could be longer for 2-3 months. You know, and for the deposit, put something on the table, and then we can proceed with the delivery. If you don't have, sorry, ma'am.
Sorry, baby. Also,
and baby, you can then go to the public health. You know, so that's where the problem is. So the issue of running out of money, you know, and people suffering serious setbacks because they seek, you know, actually healthcare is a big issue, and that's what the NHI actually seeks actually to address. No one should pay out of pocket, and no one should suffer these catastrophic financial setbacks in seeking actual healthcare.
And one of the things, as you are saying, because the NHI thing was topical, we've been reading some documents. There's a report by the World Health Organization that actually puts South Africa private care, without considering the public sector, as one of the most expensive because of how prices are set by the medical aid themselves and hospitals. So how do we, and people who are objecting to the NHI, they object because they think with their medical aid they are fine. So how do you communicate effectively to those people to say, well, you might have a medical aid, but comparatively to other countries, you are still worse off with your medical aid because you are being taken advantage of?
You know, it's I think it's 2 years or 3 years, 5 years back, there was an inquiry run by the Competitions Commission, the Health Market Inquiry.
I remember that.
Their findings there, it was clear, you know, that there's overcharging,
There's also collusion.
there are over-servicing, there's a lot of wrong things that are actually happening in the name of profit, you know, and that what makes the expensive nature of private healthcare. And in this space, we still see patients not getting enough treatment because medical aid ran out, or the medical aid is not, the option is not covering that and that, or you have to be in hospital for you to do an X-ray.
Yes.
you know, you cannot do it as an outpatient. You know, so the health market inquiry expressed and exposed some of these things that we were somehow anecdotally, you know, as activists complaining about. But what's interesting is that there are health activists who always talk about fighting for access of individuals to get healthcare. But I have never seen any case or them taking any private hospital or any hospital group or anyone to court to say that you cannot deny this person this bed, you know. But if it is something that they think is wrong done by government, they will definitely take government to court, and they do it without a flinch, and they will criticize, you know. But when it comes to private healthcare, expensive as it is, denying people access as it is, people paying, because people pay premiums, you know, they pay, but they still don't get the full service that they pay for. And you find some health activists who see it as okay.
Yeah. And like you said, that sort of double inconsistency almost, right? Because there is this different set of rules. And that's what I started off by saying when we opened the podcast. And I don't mean it dramatically, I mean it very truthfully. There is a medical apartheid, right? There's one set of rules for one group of people and another for basically the black masses. But I want to finish up on this medical aid kind of concept. You know, they're up in arms, everyone's losing their minds, etc. But medical aids are not going to be completely thrown out. They're going to have a role to play. Am I right?
Yeah, it will be a relegated role, you know, because the benefits and that are covered by NHI, you know, they wouldn't be covered by, you know, medical aids. And I think one of the issues that we need to say is that even those who don't have medical aids actually contribute something for those who have medical aids, you know. So you know, people must also understand that whatever we contribute, even if you don't have a medical aid, you contribute. You know, there's tax rebates that are there, there's subsidization that people get, and all those is also on the base and the backbone of, you know, the fiscals. So it's not like people who've got medical aids, it's only them. You know, we also, all of us, the whole population, you know, contribute for that a small percentage of people to have, you know, access to medical aid. So the issue of taxes increasing, because there's that also talk about taxes increasing. Of course, if you have a medical aid, if you opt to choose that you keep your medical aid outside, there are some of the grants or the what we call this, the incentives that you will get, you know, or benefits that you will get from being a taxpayer, you know, that will be taken away, you know. So you'll be strictly paying it from your without any subsidy or any help from, you know, the fiscals or government. So the tax, anyway, there would be some form of tax that will be there, but it's not the way that people have been calculating.
No, I think I'm sorry. I'm going to stay on this point a bit because
you have strong views on the medical aid.
I fought with some people because I said online that well, even when you are on medical aid, you get subsidized by government.
That's true.
Personally, whenever I go to a doctor and the medical aid doesn't pay, I keep that invoice. I tally them at the end of the financial year. When I do my SARS return, I give them the medical, what we call tax certificate.
That's it. The IRP5.
The medical remittance.
So I get that one, the certificate from the medical aid first, plus also the things that I paid out of pocket for. and I get reimbursed by the SARS for actually
We're coming to you for our tax returns.
Yeah,
We're coming to you at the end of
so
the
when
next
I,
year.
when I said to people, actually government, even if you are not on medical aid and you are not on GEMS, you do get a subsidy, and that subsidy, the health minister spoke about it when he was on the podcast, to say those monies will be reinvested back to the NHI, so that even our bill for the NHI won't be as expensive.
You know, the other part is with all the other, not schemes, but the agencies that are collecting funds on health related, like the compensation, employer compensation, and the workmen's, I don't know what it's called now. You know, the COIDA payments, people who get injured at work, you know. What they do is that most of the time they are taken to private hospitals. You know, if somebody gets into, you know, like the George.
Yes, the George collapse.
Yeah. Yes. The first point, if they were not died, if they've not died, then their soul rest in peace, and hopefully those responsible must get. But the issue is that that amount of money, usually people ring-fence it, even in those funds, for private health groups. You know, they wouldn't take those patients to Bara, for an example. You know, even if they get to Bara, as soon as people realize that actually it's not going to be them paying or the state paying, it's going to be the compensation fund, they will be flown out to a private hospital, you know. So there's a lot that people, you know, the COIDA, you know, and in the workmen's compensation and so on, that people don't realize that it's there and it's government. And with the NHI fund, it's just going to create the fund to be able for us to pay for everyone, you know. And of course, it doesn't take away the point that we have to improve our hospitals, we have to improve the, you know, the quality of healthcare. But it just means that we'll be paying. Even now, people who are unable to pay, who pays for them? They don't have medical aid, even if they come to Bara, you know, they are tariffs.
It's the state,
so it's government. So the NHI fund is just the issue of pulling all the resources together that are aimed at giving healthcare into one fund, and then be able to purchase and procure those. But our priority will always be the public healthcare.
Yeah. I want to deal with another thing that's been, I think causing a lot of fear. And I interact with people all the time, whether it's in community meetings or public meetings, house meetings, etc.
Your door-to-doors.
The door-to-doors. People are saying, well, if we introduce NHI, which, I mean, we've signed it into law, and let's also be clear for those who are watching, it's a progressive realization.
Yeah.
Yes.
So it's not going to be like, today, this is the system, tomorrow.
It's a system overhaul.
No, I mean, effectively we are overhauling a system, but we're doing it in a responsible way. So it's progressive. It's step 1, step 2, step 3. But with that said, everyone's saying, well, there's going to be this mass exodus, this mass leaving of our top doctors, of our top trained surgeons, of our professionals, of our best nurses, that they're going to just run and leave the country, and then the public healthcare and the private healthcare system is going to collapse. You know, doom and gloom. I think that's how Minister said it. And I interact with that all the time. And I actually want us to talk about it openly, because we need to correct some of those narratives.
Okay, there are two things that I want to mention. First is that I think our government must have an obligation to employ all health workers.
Yes.
You know,
we agree on
they
that.
have to have obligation. We cannot give excuses about budget cuts and so on. You know, it's disheartening.
Essential service.
You know, it's essential service. It's disheartening where you train, because we train. You know, it's our subsidy, it's our money, where we train doctors, we train nurses, and then after the training, we then tell them that, sorry, we cannot employ you.
So down with austerity.
You know, so we, you know, on that part,
True.
I think we should be very clear that every healthcare worker, you know, should be employed. You know, and at some point we are running some form of a campaign. You know, we started off as a campaign to say, asking doctors and specialists and so on to volunteer their services in 1 or 2 clinics, you know, just to keep them also in the system, you know, to give their service, because they are for waiting time. You can reduce it if somebody can come and donate 4 hours of their time, you know,
Sure.
just to increase the people.
Means the lines are shorter, people get it.
So for me, that's the first point that we need to make, and I think even the minister must know that, and the president, that we as the public and as ANC, you know, we want healthcare workers to be employed, all of them. You know, they must have a role to play in the public, actual healthcare system. Then to answer your question, there's no way in the world where there's no equivalent of an NHI fund, you know, a government-run health fund. You know, go to Australia, which is popular destination now, Australia and New Zealand. They have one way or another this form of funding. You know, you go to Canada, it's the same. You know, you go to London, it's the same. So everywhere, you know, where you go, you know, you are going to find an equivalent of a government-run national health fund. You know, and so it means for them it's not about the fund. You know, it's about something else. You know, which we can then have a different conversation with them of why they tend to, you know, to want to leave the country. But when it comes to the fund itself, everywhere, NHS, in Australia, I think in one of the radio shows, they were interviewing a GP from Australia, was just describing exactly what is proposed in the bill, you know, or in the act now, you know. So I don't know what people are fearing, you know, we shouldn't cast aspersions. But for me, there's also a sense that because of trust, you know, lack of trust of whether we're going to be able to run the system quite well. And we don't take away, you know, those fears, you know, we shouldn't discount them. You know, the issue of powers to the minister, you know,
the capacity
from
of
the
state.
Zondo Commission, we'll see that, you know, there was a bit of a problem with the powers and unfettered powers to the minister. So we need a way to actually to manage it and make sure that there's accountability and there's participation. One thing about our democratic system is that it's a quite transparent system, you know, how judges are interviewed and appointed and so on. You know, now it was the PP, the SABC board. So we have been learning on how we increase the accountability and transparency to make sure that we don't get one individual with all the powers without actual consultation. And that's our big lesson for the 30 years that we've been in power. So that's the first point that is there. And also that, you know, NHI fund is likened to be like an SOE, you know, like it's going to be like another state-owned, failing, you know, state-owned enterprise, you know, as comments on. And they tend to forget that there are almost over 40 other, you know, public entities which are stable, are functioning, particularly the 3A, you know, public entities which are functional and doing their work, and they're doing well. So it's just a matter of how we communicate it, and also as the ANC, we build confidence. You know, and I think what we have done with learning from the Zondo commissions and all the other things is that there should be systems that we put in place that make sure that we don't give overall power and we don't confuse, you know, roles, you know, as you know, as politicians, administration, and so on. So I think we have learned, you know, and we have turned the corner, I suppose, you know, with SARS coming back into full functioning. It means something is coming all right. You know, ESCOM now, you know, which is doing well so far, you know, and we see the momentum, and we see that it's going to be one of the good lessons that we have learned over the past 30 years. So there's a lot. So for them, maybe there should be and might be another reason, you know, which maybe is associated with lack of trust in terms of our government and
But just before this, there's two things on that, right? And I think we sometimes forget. The NHI as an act has been signed. but there's still a process to implement. And of course, now my legislator's hat is on.
Yes.
There's still regulations, right? There's still the nitty-gritty. So what people don't quite always understand is that the NHI is a broad framework of what we've discussed, right? We want universal healthcare coverage, which, by the way, the World Health Organization, the UN, all of these international bodies, which is why all these other countries have it, they recommend a national health kind of coverage, right? Because it only makes sense. But it's an overarching idea and concept. So now during the regulations, which are still to be promulgated and, go out for public comment, etc., there's still an opportunity for us as South African citizens, for doctors, for nurses, to come forward and say, okay, we agree with this, we disagree with that in terms of running. So this idea that the door and the book is shut, I don't think that's true. It's not.
Yeah, I think there are two things. Okay, we are talking about the NHI fund. We are not at the point where we are reflecting on the healthcare system itself. NHI fund is just one part of how we're going to fund and procure services for citizens. And
it's a resourcing question.
The act is clear. It's about the establishment of the fund. The other parts that we've been talking about, the quality of healthcare, over-servicing, and all those things, are part of the healthcare system that we still need to continue to transform. But we need to be able to fund a point on how we are going to purchase services for citizens. And that's the fund itself. So the fund, the act on its own speaks on the type of fund. The public entity will be the board, the CEO, the committees, and the whole range. So we still have to talk about the real sense. How do we then give the universal health coverage? How do we provide universal health coverage with the ability that is provided by the NHI fund to procure services for our citizens? So we still have to have a conversation, and I think we've been doing it, but it just needs a greater momentum in making sure that we change the mindset of being people waiting to be sick and then go to hospital.
Yeah. And also, I think when the minister was here, I asked that question about corruption. That people are correct. In South Africa, corruption is one of the biggest challenges that have been identified by the ANC itself as a challenge. As you mentioned, the Zondo Commission, the things that we've had there for over 2 years. So people are concerned when a minister is going to be responsible for a fund. And it is a fair concern, but at the same time, I think it also ignores that we also, as you are saying, have entities that work. We also have funds that do work, like your unemployment fund. You have the PIC itself, because it is a fund. It functions, it funds companies, it creates, in fact, it backs the economy, it makes it function, and it is managed by the finance department. You have the National Student Financial Aid Scheme. It has problems because problems are inherent, I think, in a system that is managed by people. But
as a concept, we all agree, right?
Yes,
NSFAS is necessary. It's just the administration thereof.
Yes, for example, there's in 2023, NAFSA has funded 1.3 million students. So no one is going to tell me now, let's shut down NAFSA because someone stole probably some money there, which they should not have stolen.
And therefore dooming millions of young people in this country.
So it's not quite a good justification for me to say, well, let's not have the National Insurance Fund because everyone is going to steal. It's not really a good justification, because you have all these funds that have been functioning well, that have created businesses, that have created graduates like myself. You also have, for example, a SASA. I know it's not really a great example, but SASA is responsible in terms of corruption itself, because there's been talks around it, but when it comes to reducing poverty, it's quoted
social security.
Yes, social security has reduced the number of people who can have food. It has also made sure that people stay in school so that they finally graduate eventually. So there are funds that we can use as example that do function. There are problems, we're not denying them, but these funds function and they do greater good that is measurable. So the insurance, the health insurance won't be different to any of that. But I wanted to go back to the issue of doctors, because there's this idea. I've spoken to a number of doctors myself. So there are those who are concerned, they don't support, and there are those that,
that
do not like that do support. So one of my friend Tamsang, I'm sure he's going to murder me.
He's gonna watch the podcast.
He said he has a friend who works in Eastern Cape, but like private business, but stays in KZN. So when the bill was actually announced to be signed, he actually said, "Hey Tamsang, when this bill is signed and is law and it's practical, I can actually go open a facility in Eastern Cape in a rural area, because there I will be assigned patients and I will have an assured stream of income, because the income won't be determined by the person's pocket but by government." So there's this idea that the NHI will only disadvantage doctors. So I wanted to get clarity.
No, it won't.
Are we beating them up with the
No, it won't. In a way, there's something called when we did the pilot, the NHI pilot. One of the recommendations that come from the pilot is that private practitioners, whether in optometrist or whoever, it will be better and well suited in an NHI system, to work as a group. So group practices of a nature, or like a medical center, where everything is one-stop shop, and that's one of the recommendations. And part of the GPs and practitioners to get access, they would definitely going to have a number of people assigned to them. There will still be a discussion whether they will be paid per capitation or per patient. It will depend on different models. As you've said, that regulations have not been put up, but in terms of discussions and negotiations, it will depend whether you are paid upfront for the population group that you are responsible for, or you pay per patient. And we know sometimes paying for patient will normally somehow the whole way things it creeps in some negativity, because other people, the quality reduces. They are just going to be pushing numbers,
like a conveyor belt. That's a view as well.
So, but the issue is that we support group practices. I think health practitioners are going to actually benefit. And I make a point, Esethu, that the NHI would be like the lowest option in the medical aid. And of course, maybe the practitioners that are threatening to leave are the ones that are clear that they don't see patients of those options. It means already it's not about the service that they provide. It's not about anything. It's only about what they make at the end of the day.
And by the way, the NHI benefits ordinary citizens like us, because I think there's attempts to look at how we get charged. So often with specialties, it seems arbitrary when you get the amount that you're charged, you submit to medical aid, they pay 1/3. So I don't know if I'm correct in understanding NHI, that it also is going to help ordinary citizens like us not be taken advantage of by all these different private practices over and above medical aid.
The whole aim, as I've said, is people not to pay out of pocket at a point of care, So that's what NHI is a big game changer in procuring the healthcare services. And mind you, it's not like the private healthcare will definitely fall out of way. If Milpark, for example, gets accreditation to give services to NHI, they will, to the NHI fund, they will be part of the network, and they will get a fair share of their actually patients. All the other hospitals, it's going to be the same. So it's not like they are not going to play a role, but maybe the issue that they won't be charging what they are charging, or they will be free to charge. It will be a negotiated
which helps
and so
60 million people like us.
All of us. And one question I think I forgot to ask is the question about the affordability of the system first when it comes to individual taxpayers, because we're already paying tax. So there's a lot of misinformation that is happening. And I think it's misinformation that comes from medical aids. So when medical aids say taxes are going to go, I think they said 1,500. That's how they are going to increase. There's one I read. So they were quoting a number of figures. Has government made that determination? The misinformation that we are reading out there, is it fair, or should we be scared that our taxes are going to increase?
Of course, there will be a tax introduced on NHI, but also most of the tax that will be going there will be coming from the sin tax. They'll be coming from the compensation and other tax streams. But the issue that currently, as we speak, there is money. There is a budget that is given to healthcare, which has to look at goods and services and everything. But then we need to be able to help and assist to put up this fund, which the tax introduced, the one that is going to be introduced, will help just to increase that part. But it means for those who are on medical aids, they wouldn't be paying medical aids anymore. So it's a relief to them. The subsidy, of course, will come out from there. So the subsidies that we give to those will now be coming here. So the calculation, I think it will still require people to do a proper. I saw one on business tech or something. Someone was making a lot of calculations, and I'm not sure about how he gets to that point. But what we know is that it's not going to be a catastrophic tax increase, but it will still also, in other quarters, relieve individuals from the tax and
just before we move for closure.
I want to give to you now, but one last one is the issue of the piloting. A lot of people, when the bill was signed, they said, well, government is just signing this thing without any preparation. And some who do actually read were talking about the pilot and its outcome. And they were using the outcomes as justification.
And they said the outcomes were very negative.
Yes. So I wanted to because I read the report, I thought it was quite a balanced report, but I wanted to hear it from a doctor to say what were the outcomes.
There are lessons, that and recommendations. I think one of the bigger one is the issue of infrastructure, which deals with the quality of the care, not the issue about the fund. I think we must also differentiate because most people in their discussion now, they are talking about the quality. They are not talking about the funding, and procuring of healthcare. So one of them is the improving, our facilities, and we know that we have a standard. A board that maintains our standards, the Office of Health Standards Compliance, which goes around, give accreditation and give some form of a report and ranking whether you qualify or not qualify. So the OHSC's work is to
you qualify
do that,
to be an NHI
center or not. So all the facilities of government have been going through the same audit for the past 10 years now. Clinics improving, on how clinics can improve, and the recommendation that comes from those reports have made it clear that there are few things that we need to change of managing waiting times and so on. The second one is the issue of what they in the report they call warbots, which are community healthcare workers in essence. And the idea of community healthcare workers is a revolutionary idea because it says you can actually prevent, it's preventative, and you can receive your health care at home, particularly for those who are on chronic medication, who require to go to the facilities. So remember, the main complaint is waiting times for people who come to clinics for their treatment. So if you reduce the waiting time, you improve the healthcare system. So for the chronic patients and those who require surveillance or TB and so on, the community healthcare workers are the ones that run the streets, that will know the patients, and that will make sure that they decongest the system. So one of the recommendations there was about community health care workers, that they need to be professionalized or introduced or built on. The third one was on the infrastructure robots. The third one was on collection of medication, you know. So the central, now we've got what we call a CCMD, you know,
And
a
it
central
was very
where,
positive on that one.
Yeah.
So those are things that are evolving, and they need to be put into place to improve the quality. But the quality is not going to be improved first, and then then before we can be able to procure health for the people.
Yeah.
You know, we need to be able to procure for the people
While improving.
whilst we improve. And there are few things that we are on track, you know, in improving. Like I've said, the first step is prevention, is moving away from the hospice-centric mentality. All of us must have a responsibility to take care of ourselves, because there won't be any amount of money or budget that will be available that will be enough. You know, if that was the case of money being available, you know, the richest countries in the world, you know, would be not having the outcomes that they have, the health outcomes that they have, because they have all the money, you know, but they don't have, you know. We compare them in terms of Cuba and United States and so on. So you will see the disparity, that you don't really need money to improve the quality of life and the quality of healthcare. You just need the reorganization of the healthcare system and the mentality. With Cuba, average age now, it's around 82, 90. And it's all about prevention, what they do. So it's not about money, ultimately, in terms of quality and the good outcomes that you have.
No, thanks. Thank you, Comrade Dr. Bandile, and to Esethu. This was another episode of ANC Connect. But just before we close, there's a few things I want us to close with. The NHI might seem like a very scary thing. Any sort of transformational agenda may seem like that. But the reality is we need to provide quality and fair and equal healthcare across the board. And the ANC-led government is trying to do that in the best possible way. Today is not the end of the conversation. We're going to continue. We're going to allay all of your fears, not only doctors, not only nurses, but our citizens, because the fight against corruption is also fundamental to the realization of NHI. And we will see you in the next podcast. Thank you.